All right, there we go. Hey, everybody. This is Paramedic Graham Judd with YouTube Medics, and it's been a long time since I've seen you, so I'm excited to see you again. And man, y'all are looking mighty fine today. Uh, got some great news. I have recently received a job as an EMS program director, so hopefully over the next several weeks, several months, I'll have some more content that I can add. The primary goal being obviously education. That's really the main goal of this. If I entertain you in the process, that's phenomenal. Um, but today, what I want to talk about is intubation. And the reason I want to talk about intubation is because I've seen a lot of scuttlebutt lately through podcasts, through articles, through different boards and stuff like that. And it seems like people are talking about removing intubation from pre-hospital care. And in my opinion, that is the most awful of all awful ideas in all of awfuldom. Because intubation is essential in pre-hospital care. It may not be essential in every single circumstance. There might be times where supraglottic airways are fantastic. However, intubation is the only way to truly isolate the trachea. That's it. It is the gold standard in airway management. You don't walk into ICUs and see people getting ventilated through eye gels or through combi tubes or through King airways. And the reason for that is the bulb, when you blow it up on the end of the endotracheal tube, helps to secure the trachea and prevent any particulate or contaminant from getting down into the airway, and thereby helps reduce the opportunity of anybody getting aspiration pneumonia. Now, does that mean it's foolproof? No, absolutely not. I just had a leaky water heater. I can tell you that water can get through anything. So there is always a chance that there's fluid that could get past the bulb. However, it's the best tool we have to isolate the trachea. And therefore, we need to continue to use it. Hang on one second. Let's see. Ooh, somebody added me to a Facebook page. Anyway, that's the best way to isolate the trachea. And, you can say, well, I've seen so many esophageal intubations, or I've seen so many paramedics who have created hypoxic brain damage, or whatever the case is. Then the problem's not intubation. The problem is the training and the skill and the education of the provider, not the equipment and the tools and the procedure itself. So if you as a provider are not confident in your skills, you need to get back into the lab, you need to contact your medical director, see if you can get an OR rotation, whatever the case may be, to sharpen your skills. As an EMS educator, I can tell you that 5 SIM-man intubations in a lab with your instructor is absolutely insufficient for them to, slap a patch on your shoulder and here, go intubate somebody, on the side of the road or in a living room floor, or someone who's actively vomiting. That's not good training. It's not enough training. And if that's the type of training you had, go to your clinical coordinator and get more training. Get in there and use, a bougie. Get in there and use a combi tube. Get in there and use a King Vision. Practice your surgical airways. Practice your needle cracks. Get in there and refine your skills. In EMS, we don't need to practice a skill until we get it right. We need to practice until we can't get it wrong, because our ability to perform certain skills in the field truly do affect people's lives. Don't be subpar, and don't be a poor performer. And here's the other end. Some of us are trained in pre-hospital care. I think I'm getting a call. Some of us are trained in pre-hospital care, but then we're not given the tools once. It is not me. Once we get out into the field, we're not given the tools to perform the job. I'll give you a for example. Studies show that 40% of all the success rate of intubations without any medications, without any sedation, without any paralytics, anything like that, your success rate is only 40%. Your success rate with medically assisted intubation is only 60%. The success rate of endotracheal intubation with RSI in the pre-hospital setting is over 80%. And then the success rate of orotracheal intubation, endotracheal intubation, whatever you want to call it, with the use of RSI and video laryngoscopy is almost equal to that of a physician with a 93 to 97% success rate. So why aren't we given these tools? So this is kind of a twofold issue. Number one, you as the provider need to make sure that you're up to par on your skills. You need to make sure that when you go to get a tube that you get the tube. And if they're not offering you the training at school, if they're not offering you the training at work, you need to go out and you need to seek that training yourself. Then it's the obligation of the employer to make sure that we have the tools that we need to do the job. We need to have RSI, needs to be universal, bar none. Studies show it. Study after study after study after study shows that RSI is the most efficient way to establish an airway on a patient. Now, I don't care what drug you use. I don't care if you're, rocuronium, vecuronium, sucks. It doesn't matter. That's going to be up to your medical director, not me. But RSI needs to be the standard, period. Then we need to incorporate video laryngoscopy. If you have King Visions on your trucks, that's awesome. They work great. I've used them. But we need to have King Visions on the truck too, because at that point, when we have a comprehensive training program and we are given all of the tools that we need to perform our job, we can then near a 93, 97% success rate. And even in the in-hospital setting, your success rate is only 97 and 99%. It's not 100% even in the hospital. So we also need to have supraglottic airways for the times that those are needed, and we need to have surgical airways or needle crikes for the times that those are needed. That being said, I need coffee. My mouth is dry. That being said, with supraglottic airways, I hear a lot of people saying, "Oh, we just need to drop an eye gel. Oh, we just need to use this or use a King airway or whatever." Ugh. Look, I've had an HIV exposure at the end of a combi tube. Mucous membrane exposure because the guy went up the tube and it went in my face, and it was not cool. By the way, I've never been pregnant, but I think I know what it feels like because when I was taking AZT, I woke up every single morning and puked. So I've had morning sickness. It was really weird and it kind of sucked. I don't recommend having an HIV exposure, so if you can avoid it, by all means, please do. So needless to say, I refuse to use a combi tube, period. It's not going to happen. That was the last time I used it, and that was about 7 years ago. But I've seen eye gels that don't seal. I have seen King airways, when you blow the bulb up, they pop back out into the mouth. I showed up on scene of a cardiac arrest, and the patient's got the bulb in his mouth, and the firefighter's like, "Look, I'm helping." So I'm not a big fan. You know what I'm a big fan of? I'm a big fan of honing in your skills and performing your skills on a regular basis so that you are good on them, so that when it becomes critical in nature that you're actually able to do what you need to do, and that is establish an endotracheal tube in your patient. To top it off, there are times where a supraglottic airway is just going to be insufficient. If your patient is having an anaphylactic reaction, a supraglottic airway is not going to work. If your patient has laryngeal edema, a lisinopril reaction, it's not going to work. Here comes another call. If your patient, not us again. So you've got burns to the airway, you've got an anaphylactic reaction, you've got laryngeal edema, you also have chokings. You may not be able to intubate past an airway obstruction, and you may need to perform a surgical airway. Maybe you can push it down and get the tube in. That's fantastic. Maybe not. What about people who are, vomiting? You've got to isolate the trachea. What about facial traumas when they're bleeding back into their throat, or head traumas when they're bleeding into the airway? You've got to be able to isolate the trachea, and you absolutely cannot do that with a supraglottic airway. Period. CHFers. You've got somebody who's got massive pulmonary edema and they've got pink frothy sputum coming up into their airway. Supraglottic airway is not going to work. So to say, oh, well, we're just going to take intubation out of the field and we're going to use supraglottic airways because, they work, they're great. No, they're not. And no, they don't. Maybe in some situations, maybe in a cardiac arrest where they've already had a 20-minute downtime, a supraglottic airway is fantastic. First off, why are you working the code? Second off, okay, maybe they're going to work, but they're going to work in that particular instance. They're not going to work most of the time, and they're not going to work all of the time, and you've got to isolate the trachea. And to do otherwise is negligent. So if you're one of these people who's advocating that we pull RSI out of the trucks, or if you're advocating that we pull intubation out of the trucks, number one, do your research. We can, in the field, perform to basically the same exact success rate as hospital personnel if we're provided with the right equipment. It's very important to understand. We've got to have the the right equipment. And number two, you're probably no good at doing airways, and you want them to pull them off the truck so that your numbers don't suck. Let's be honest here. If you were good at establishing an airway, you wouldn't want it pulled off the truck. Anyway, that's my 2 cents, and I think it's probably the longest video I've done. But anyway, I'm all spun up, so hey. Anyway, drop a comment. Tell me your thoughts. What does your service use? Do you use etomidate? Do you use sucks? Do you use fentanyl for continued sedation? Do you hang propofol drips? Do you use rock? Do you use vec? Do you use sucks? I'd like to know. I'm curious. I've worked in a few different systems. We've all used different things. Here I have medically assisted. It's Versed and fentanyl. Let me tell you how excited I am about that. I worked in another system where we had absolutely nothing, which was even worse. Worked in another system where we had etomidate, which was fine, unless it's a trauma patient, because you know what trauma patients do when you give them etomidate? They clinch. And then I worked in a very aggressive system where before I left, I was 20 for 20 out of 20 intubation attempts. And since then, even with the very few tools that I have, I'm like 8 for 8 out of 8 attempts. You know, you make best with what you've got. But the first thing you do, practice till you can't get it wrong, not till you get it right. God bless you guys. Have a great day. Hope to see you again soon. Love you. You look great. Leave me a comment. Share the video. Bye.